Chapter 27, Complications of Labor and Delivery. In labor and delivery, we talk about the 4 Ps: the powers, the passenger, the passageway, and the psyche. We talk about the influence of those 4 Ps on labor and delivery, and you'll hear me use that terminology of the 4 Ps throughout this presentation. Our first slide, we talk about dysfunctional labor, problems of the powers, so ineffective contractions, contractions that are not adequate enough to facilitate cervical dilation as well as labor and birth. Ineffective maternal pushing, again, problems with the powers there. Perhaps the mother is unsure of where to give effective power, where to give effective pushing, and needs a little bit more guidance and or reassurance. Problems with the passenger, in that we talk about fetal size. Our slide 3 over here, we see some illustrations of problems with the passenger, where the fetal size might be affecting the ability of the fetus to deliver. We could see a mixed Roberts position, which is where a mother kind of brings her knees way up into her shoulders or way up towards her chest to allow facilitation of the fetal shoulders to deliver. In illustration B, we can see suprapubic pressure being administered to help facilitate the fetal either anterior or posterior shoulder deliver under the pubic symphysis for vaginal delivery. Slide 4, we can see mom on her hands and knees and 2 fetuses there in this illustration. Problems of the powers include ineffective contractions, which we discussed previously, as well as the maternal pushing factor. Other problems with the passenger include fetal size, abnormal fetal presentation or position, which can affect a baby's ability to be born vaginally, multifetal pregnancies, as well as fetal anomalies that might affect delivery. In A illustration on slide 6, we can see a frank breech presentation where the fetus is being presented. In B, that is the delivery of a breech fetus, and C and D are also more detailed deliveries of a breech presentation. Once the fetal body and legs are delivered during a breech presentation, it's important that the healthcare providers facilitate the restitution of the fetal head to complete delivery and prevent uterine contractions from head entrapment. The next illustration, we have lots of pictures there of twin gestation and their various presentations and ways that they might present. Other dysfunctional labor issues include problems with the pelvis and the structure of itself, as well as soft tissue obstructions. When we think about the pelvis, we want the baby to be able to kind of fit through the pelvis to accommodate a fetus being delivered through there. We want to avoid CPD, which is cephalic pelvic disproportion, also known as kind of square peg round hole, where the fetus for some unknown reason is unable to kind of fit into the pelvis. It might be that the pelvic arch is too narrow and the fetus is unable to be delivered via vaginal delivery. Abnormal labor duration includes a prolonged labor, labor that is really extended in duration of time, both in the first and or second stage, or perhaps both. And a precipitous delivery is a delivery less than 4 hours from the start of the first contraction to the delivery of the fetus. Slide 9, we get a better illustration of pelvis size and shape there to talk about that cephalic pelvic disproportion again. Application of the nursing process in intrauterine infection. We want to talk about assessment. Again, getting your baseline vital signs are always going to be crucial in how we manage and care for our patients. Understanding the nursing diagnoses that are applicable to patients who experience infection during their labor and delivery. What expected outcomes do we have for moms who experience infections during labor, as well as what outcomes can be seen in the fetus. We want to reduce our risk of infection, so we want to talk about interventions that can reduce risk of infections. For example, advocating for appropriate vaginal exams for patients, so they're not on a schedule every 2 hours to assess for cervical change. Perhaps it could be more clinically appropriate if the patient has various contractions, there's feeling pressure, something that would kind of advocate for an exam versus a more regimented schedule. We want to make sure that we identify infection as soon as it happens, and then we want to evaluate our effectiveness for our interventions. We also want to think about the following interventions in cases of maternal exhaustion. Assessment, what is this patient's baseline? Did she come in already fatigued? Is she undergoing some social issues that are contributing to this fatigue? How is she supported? What nursing diagnoses are applicable to these patients? What is the expected outcome for a patient who's experiencing maternal exhaustion during her labor and birth? What nursing interventions would be applicable to her, and how do we evaluate the effectiveness of those interventions? Premature rupture of membranes is the rupture of the amniotic sac prior to term gestation. We want to talk about what are the complications for this? What is that patient's risk for infection? It's going to as well be very case specific for patients for patients during specific gestations. Some patients might rupture their membranes preterm and require some steroids such as betamethasone to help the development of the fetal lungs become a little bit more mature. What are some other therapeutic managements for these patients? Do we tocilize these patients? Do we add to their labor process and expedite their delivery? What are some nursing considerations that we have for this patient population? Preterm labor, another complication of gestation. What are some associated factors? Think about a patient's baseline history. Does she have a history of several preterm births, or is this her first preterm birth that she is experiencing? What are some signs and symptoms of preterm birth? Things like advanced cervical dilation or rupture of membranes. What are some ways that we can prevent preterm birth and advocating for prenatal care, and some therapeutic management of preterm labor? Are we going to stop this labor by tocilizing a patient? Are we going to augment their labor? Accelerating fetal lung maturity, again, adding to the betamethasone or the steroids that we can give antenatally. For preterm labor, what are some psychosocial concerns? How is the mom coping? How are support people coping? What are some nursing diagnoses that are applicable to those things? What are some expected outcomes? If a patient comes in with preterm labor at 26 weeks, we should definitely discuss with that patient what are going to be the outcomes of this 26-weeker. How does she prepare? How does her family and support people prepare for the birth of a 26-weeker? How does the NICU play a role? What are some interventions that we can do as nurses, and how do we evaluate them? Prolonged pregnancy. Prolonged pregnancy is greater than a 40-week pregnancy. So 41 weeks, 42 weeks, we call those post-dated pregnancies. And they do have their own inherent complications as well, including issues with the placenta and circulatory system. We know that a placenta is pretty good for about 42 weeks, and after that we start to get highly concerned with the perfusion of that placenta. What are some therapeutic management or some interventions that we can do as nurses for these patients? How do we support a patient who has a prolonged pregnancy? Intrapartum emergencies include placental abnormalities, such as a placenta abruption, again, when that placenta is tearing away from the uterine wall. A prolapsed umbilical cord, typically found inpatient in the hospital by an examiner. And a prolapsed umbilical cord is when the amniotic sac has been broken and the umbilical cord falls through the cervix into the vagina, and sometimes even exteriorly. Uterine rupture. Uterine rupture is typically seen in patients with a history of uterine surgery, such as C-sections or hysterectomies, not hysterectomies, or other uterine surgeries. And a uterine rupture is when that scar from previous uterine surgery starts to open, and this uterus itself completely opens, and the baby potentially could be free-floating in the abdomen. severe obstetrical emergency there. A uterine inversion is typically occurs postpartum when the uterus itself kind of folds into itself in a postpartum period, causing some issues not only with the organ itself but also with bleeding, as well as any kind of trauma that can occur postpartum. In the following slide, 19 of 23, we can see some examples of a prolapse cord there. The first is an occult, a hidden prolapse cord there. It's compressed between the fetal presenting part and the pelvis, but cannot be seen during an exam visually, externally, or through manual palpation. Cord prolapse in front of the fetal head, and again, that's where the examiner would be finding this prolapse of the cord. The cord is presented as pushed against that fetal head close to the cervical opening. The last photo is a complete cord prolapse there. During a cord prolapse, again, true obstetrical emergency. In these types of situations, we usually have all hands on deck in an obstetrical unit. So the healthcare provider who's discovered the cord prolapse, what they try to do, and you can see that visualization in the first photos, they try to kind of push forward that fetal head to decompress cord compression. They oftentimes have moms get onto their hands and knees to kind of help gravity a little bit decompress that compression of the cord, and then they typically move to the operating room and proceed with an emergency cesarean section. In slide 21 of 23, we can see a uterine rupture there. This is not a complete uterine rupture. This is a semi-complete uterine rupture where part of that uterus is open, exposing the cord as well as exposing some fetal parts there. We always want to understand our role in any type of emergency as nurses. How do we assess? What nursing diagnoses are applicable? What are some expected outcomes, interventions, and how do we evaluate these outcomes? Slide 23. What action should be initiated to limit hypovolemic shock when uterine inversion occurs? So hopefully once you have completed the readings for this week as well as the PowerPoints for this week, you'll be able to answer this question with success.